Hello everybody, welcome to Dental XP. My name is Bernardo Mira Correa and I'm from Oporto, Portugal. All around the world, people seek their dentist to get their radiant smiles. And whether through a digital or analog smile design treatment plan, soft tissue management is often required. We understand that enhancing the soft tissue's amount and quality around natural teeth or dental implants is a predictable way to get aesthetic and long-lasting results for our patients. So we generally like to enhance the soft tissues and start from this initial situation into this much more favorable situation, because like David Garber says, bone sets the tone, tissue is the issue, and me and Felipe Lopez, we like to add that thick is fit. We like fit tissues around our implants or natural teeth. And there is no doubt about the aesthetic gain, and this allows us to achieve, well, our patients' expectations. So in this situation, the soft tissue management was achieved by using a acellular dermal matrix graft that was biomodulated with prgf. For a long time, we had this feeling that enhancing the soft tissue's thickness and also trying to get keratinized mucosa around our dental implants was a very important criteria for achieving stable and long-lasting results. But there was no scientific evidence at the literature. In 2009, Thomas Linkevicius and his team concluded that gingival thickness may have significant influence on marginal bone stability around implants. This was very interesting for us to have our opinion and our feeling scientifically supported. So the soft tissue management is indeed important in many situations, and we consider that we need to do a bioplanning, a biologically supported plan to prevent problems in the future. In this case, particularly, we do an epithelial connective tissue graft prior to the implant's placement, so we can achieve an adequate biological width. Sometimes we need to do soft tissue management after implant placement, and I think we all agree that when we see this situation where we have the buccal aspect of this implant surrounded by alveolar mucosa, we all agree that this is a very high risk situation for developing perimplantitis. So we need to change the periodontal biotype, and again we go to the palate, we harvest an epithelial connective tissue graft, and we were able to achieve much more reliable soft tissues around the dental implant. And I guess we all agree that this situation is a much more favorable situation than this initial one, and by getting this type of soft tissues we can go on and finish the treatment, placing the prosthodontic work. This is a 4 years control after grafting, where we can see the stable situation of our treatment. Also, for gingival recession, we like to enhance the soft tissue thickness, especially in a more severe bone loss recession situation like this one. We like to use autologous connective tissue grafts so we can get into this final situation in a very reliable and predictable way. Especially in multidisciplinary treatment plans, we like to prevent the problems, and we know that it's very important to change the periodontal biotype, because thick is fit, and only by doing this we can achieve the pink equilibrium, because this is a treatment where we have implants, natural teeth. So the soft tissue management must be very well planned and must be a biologically supported planning. So the palate is indeed our major donation area. It's our number one choice for collecting grafts because there we can get keratinized gingiva with good access and good quality and amount of soft tissues. Of course, we can get some surgical hazards, both by the free epithelial grafting technique or connective tissue grafting technique. We can have hemorrhagic problems during the surgery or after the surgery. Reharvesting the palate at the same area can be also a problem, especially on thin periodontal biotypes, where sometimes we can have the need to go to the same palatal area to harvest a new graft, and we can find there a non-available thickness or quality for reharvesting. And also the post-op morbidity that we all know and are aware that our patients suffer. We know that these kind of approaches are really painful for our patient, especially if we need to go to a bilateral palatal approach. And even on collecting the connective tissue graft, we can have the epithelial necrosis, and we can have this situation and expect that our patient can undergo severe pain and discomfort for 2 to 3 weeks at least. So is there any hope for our patients? Are they doomed to suffer so much every time we need to harvest the palate? Well, maybe not. What if we tell you that we can go to the palate, we can collect this type of graft, and after 2 to 3 weeks we can expect to find this type of palatal mucosal healing? It's interesting, I guess. And what if we tell you also that the pain can be reduced for almost 40%? I guess it's a very interesting situation also. And how can we do this? Well, let us share with you. Me and Filipe Lopez, we developed a technique that we call the prgf-endoret graft technique. And we are going to show you how we do it. So we do the epithelial connective tissue grafting, and then we're going to suture both portion 1 and 2 of the PRGF membranes at the palatal mucosa. In 2 to 3 weeks, this is the healing aspect, which is very favorable. This is even more interesting if we need to go to the palate and harvest both sides. And we can find this type of healing 1 week after the surgery. And it's very interesting to control this type of healing with the normal second intention healing of the palatal mucosa, because it's a very similar aspect, but there is a big difference in time in between these two pictures. So one is 1 week post-op and the other one is almost 3 weeks. We published an article in 2012 trying to compare the second intention healing of the palatal mucosa versus the PRGF graft healing. And it was very interesting to see the results. So how did we do it? We got the fraction 1, which is the fibrin membrane portion, and we started suturing it into the donor's area, leaving only the mesial aspect opened for us to be able to get the fraction 2, the growth factors rich portion, and we put it underneath the fibrin membrane. Then we made a vacuum splint to protect both areas. 1 week post-op control showed this kind of differences, and it's very interesting to see that at the PRGF graft area that we can still find the fibrin membrane stabilized and attached to the donor area. And of course, at the control site, we see the normal necrotic aspect that we know that every time we look at this, that our patient is complaining about how much that part is hurting. 3 weeks post-op, we can see again major differences. So at the control area, we can still see some non-epithelialized areas which are still painful. And at the PRGF graft donors area, we can see a much more advanced healing with some peripheral areas of keratinized mucosa. 6 weeks post-op, the differences are not so big. We can find a very advanced healing on both areas. Yet, at the control donor area, we can still easily recognize the borders of the harvested area. And at the PRGF graft donor area, these borders are harder to distinguish. And this, I guess, suggests that we are experiencing a much more advanced healing. It's interesting to see that our clinical results were also found on Dr. Anijua's studies for post-extractant sockets regenerated with prgf-endoret technique. And on these studies, he could also find that there was a thicker epithelial healing, so we get a much better quality of the soft tissues, and also the epithelialization index, it's much higher. So these soft tissues heal much faster when we add PRGF versus a control situation. So these are the major advantages of this technique. We can expect a reduced post-op hemorrhagic risk, a faster soft tissue regeneration, a better donor's area availability for reharvesting, and also a very important advantage is that we can reduce a lot the post-op pain and morbidity for our patients. So we hope that you enjoy this lecture and that you can find this technique useful for your daily practice as it is for us. And we hope to see you again on Dental XP. Thank you very much.